Okay, good morning, everyone, and welcome to this morning's COVID-19 Fields Seminar. I'm going to hand you over to Kumar Murthy, who will introduce our speaker this morning.
Very good. Welcome, everybody. Another meeting of the seminar. Delighted to have Dr. Sharmistha Mishra speaking to us today. Sharmistha is a well-known figure in the epidemiological world, and she also is a member of the modeling consensus table. And she will speak to us on how to get away with inequity and outbreaks, the SARS-CoV-2 COVID-2 modeling story. Mr.
Thank you. And thank you for inviting me to join this seminar series. I really enjoyed hearing about the work of others, and I hope this this will be interesting, but also I welcome feedback, as this is this comprises a lot of work in progress. So some disclosures were funded through CIHR research, as well as for COVID-related work from St. Michael's Hospital Foundation, Research and Innovation Council for COVID-19 research, and no industry funding. So what I thought for this seminar would be helpful to discuss are some reviewing a little bit of the data with respect to what they tell us about mechanisms as they lead to inequities in risk. Mechanisms largely because that helps us understand a little bit more about what we might think about for interventions. And what insights might be gleaned from transmission modeling for the public health response with keeping that eye on equity. And I'm going to show some illustrative modeling work, largely because we're not further ahead yet with some of the other more data-driven modeling work. And I'm going to close off with a little bit more of a soapbox discussion, but I would love thoughts from folks around just how we may think about the modeling that we're doing as a community, particularly with respect to epidemiological work, guided by core public health principles around equity. So this has been pretty consistent across almost, I say most, but it's been pretty much almost every epidemic and outbreaks that we see disproportionate risks of onward transmission. And when they disproportionately affect and concentrate in specific networks, they tend to be harder to control. And this largely, a lot of our work comes from HIV, which has taught us this. And if we take a look at sort of emerging data from COVID, we're seeing a similar picture where folks have been able to actually look at secondary attack rates within households, for example, or within facilities. We see that it looks like similar to other infectious disease, including respiratory and virus infections, that 80% of transmissions or secondary infections likely arise from 10 to 20% of quote unquote index cases. And oftentimes it's hard to do some of those secondary household transmission studies. And one of the things we can look at are often this disproportionate acquisition by looking at cases diagnosed. And that becomes kind of tricky because what we'd really like to do is not just look at who is at disproportionate risk, but whether we're really talking about a proxy for an actual risk factor or whether we're talking about the actual risk factor. And so a lot of times we have to make sure that we're essentially thinking about what we mean when we say that, proportion visible minority is associated with test positivity. Is it really reflecting household density, occupation, for example, or mediators of activities or systemic racism versus it's actually a biological risk factor or risk or resilience element? And across the globe, we're seeing these data, and then I'm going to present some of the work we did in Ontario. But essentially, if you take a look at Sweden, for example, this is with individual level data, and I've highlighted here that really it's after adjustment for other potential confounders, square meter per person within the household is highly correlated with COVID-19 related death and all-cause mortality during the period of the COVID epidemic. When we look at the US data, and this is from some great work by AMFAR, where they've taken a look to see what are we seeing with respect to per capita cases in counties that have a larger proportion of the population who don't identify as white or non-Hispanic to least diverse communities. And you see sort of where cases are per capita concentrated. And so this is a story that's sort of coming out across multiple countries. So what do we find in Ontario, kind of learning and doing this work in parallel to what we've been finding in other countries? So we did an analysis of laboratory confirmed cases. And we did this with the Ontario Lab Information System data, as well as linkage and having linked it with health administrative data through ICES. And this comprises 88% of lab confirmed cases at the moment, because that's what the Ontario Lab Information System captures when we compared it to the surveillance system across Ontario. We looked at data from March 1st to June 20th, 2020. And the data I'm going to show you exclude residents of long-term care homes. And what we were interested in, it was looking essentially at what are some of these proxies or these associations with and without adjustment with respect to a diagnosis for COVID compared to a population case control, or everyone who was either test negative or never tested. And we compared this throughout across the population in Ontario, which meant that we were looking at 3.3% of the proportion tested had been diagnosed, and about 5%, 5.2% of the population had been tested at least once. We looked at individual level factors, which I'm not going to go into in detail unless folks have questions about that. But what I wanted to focus in on were the social determinants of health, these measures of equity or inequity across things that relate to how people may come into contact with each other with respect to occupation or activities via proxies for education, household income, and what we define as uncoupled status. So folks who may not live with in partnerships at home. And then we also wanted to look at things related to dwellings, so household crowding or density, and the proportion of apartment buildings that might be in the neighborhood. And then finally, ethnicity and race as a proxy for unmeasured confounding, be they activities or mediators of systemic racism. And so all of these data for us were available only at the dissemination area or neighborhood or area level, which comprise about 400 to 700 residents and are drawn from the 2016 census data. And lastly, we just adjusted for unmeasured confounding that may occur at the level of the public health unit using fixed effects, given variation across social determinants, as well as our different measures that were taken and testing practices. We also, because we wanted to look at test positive versus everyone else, we needed to also understand who was tested and who was not. And so I'm going to go over the findings from the social determinants work. So first, what you see on this, and apologies for the multiple words, is those variables at the dissemination area level that I mentioned are quote unquote exposure variables. We conducted logistic regression modeling and are representing the odds by these exposure variables and quintiles for most of them in terms of how we categorize the variables. We also adjusted for age and sex, which I'm going to skip over, and then there's a fully adjusted model, which accounts for all these elements as potential confounders. And I'm going to point out that when we look at tested at least once versus not tested during our study period, if you just take a look only at the unadjusted data or unadjusted effect size or effect measures, what we find is that lowest income households were more likely to get tested. But after we actually adjust for all potential confounders, we find that it was the highest income neighborhoods where there was the highest household income were much more likely to get tested. Moving forward, who else was more likely to get tested? Neighborhoods in which there were a higher proportion of individuals who were uncoupled. And there was least testing in the most diverse neighborhoods. So neighborhoods with the highest proportion of visible minorities were less likely to get tested. Neighborhoods with higher proportion recent immigration were less likely to get tested or have been tested at least once. So that's with respect to testing. when we take a look at cases, using this as a population case control design, we once again find sort of this dose-response relationship. What we find is that in fully adjusted analysis, odds of diagnoses or cases go up substantially when we get into neighborhoods with lower education, with higher proportion of households or individuals with lower educational attainment. Higher odds of testing in neighborhoods where there's a higher proportion population who are uncoupled. And household density really stood out as, again, a dose-response relationship between individual neighborhoods which have the highest number of people living in a household compared to neighborhoods with lower household density, giving us odds of more than 2.25 with respect to the neighborhoods with the highest household density. Really similar findings in Ontario, and this is across Ontario, adjusting even for the public health unit across Ontario, as we've seen in other parts of the world. And what's helpful to note here is that when we take a look at, for example, visible minority, where on unadjusted analysis, we see this stark relationship, as we've noted before, around diagnosis and higher proportion of the population in the neighborhood representing individuals who identify as visible minorities. But once we adjust for other potential confounders, that relationship is attenuated. And same with household income. So telling us a little bit about what are the actual potential mediators or the mechanisms by which we may think about the higher acquisition or diagnosis of cases. So I've shown you data from Ontario around the higher odds of testing as well as higher odds of cases. What we really wanted to do, and we're working on this, but I'm going to show you data from elsewhere for now, are that not only are we thinking about increased rates of cases that may reflect underlying risks, such as, for example, household density, we need to be thinking about what has happened with respect to interventions. So if we take a look at mobility, for example, here these are estimates from work by colleagues in the United States. So this is across the US, and what you see is using cell phone data at an area level similar to the dissemination area. The yellow line represents the highest income quintile neighborhoods. The purple line represents the lowest income quintile neighborhoods. And I'm going to just focus in on this completely at home. So this is cell phone pings that have been measured as having been proportioned to staying at home. So this idea of shelter in place as a proxy. And what you see is essentially who has been able to actually physically distance or shelter in place and who probably hasn't with respect to income quintile. And what we see is it's the highest income quintile that may have been not staying at home as much, changing with respect to after interventions, with respect to being able to stay at home versus sort of the lower income quintile neighborhoods. And that's reflected also when we see look at the data around median distance traveled and retail and recreation. So these are data from United States, but this is being undertaken now in Ontario as well. And the reason I bring this up is because what we're interested in when we think about disproportionate risks of transmission is also considering how does that intersect with intervention access and uptake, because we often think about age group with respect to heterogeneity, for example, but what we're seeing in addition to age group, in addition to and a component with respect to gender are those proxies that we mentioned before, proxies of occupation, of household density, or proxies with respect to income mediated through those other mechanisms. And so what if we had two different risk groups? What if we had individuals who are at lower risk, individuals who are at higher risk, and they come into contact with each other with respect to some degree of assortativity or proportionate mixing. And for the sake of argument, we say, okay, the lower risk have lower contact rates and or lower transmission probability, for various reasons, for example, perhaps through household density. And then there's individuals who are at higher risk. And then we provide an intervention, for example, strategies to reduce contact rates. And the question is, what exactly happens? Who reduces their contact rates? And is it proportionate to what they were, their contact rate before? Is it equal reach? Is it unequal reach? And how might that play out with respect to some of the data that we are seeing around disproportionate risks with respect to the odds ratios, for example? Another way we can kind of think about this, beyond looking at odds ratios and relative risks, and what I'm trying out is approaches where we can actually use this to calibrate our transmission models. So let's zoom in to the city of Toronto. What you see on your left is a map of the city of Toronto showing per capita cases, excluding individuals or cases in long-term care homes, by the dissemination area. And what you sort of see are these marked areas of concentration. And these are data up to August 21, 2020. And on your right, what we show is a Lorenz curve. In a Lorenz curve, we've got the line of equality or proportionality, where cumulative proportion of the population, and here, because we don't have individual level information on this, we have the population size by the DA or the area level. And these are the key, and on the y-axis is the cumulative proportion of diagnosed total cases by DA, excluding long-term residents. And what we see is that this line of equality is not followed. So the further away we are, either above or below, we're either disproportionately lower or higher with respect to how cases are concentrating. And what we find is that if 25% of the population account for 63% of the cases, and that's how we would read this Lorenz curve that we can draw out. And through that, we can estimate the Gini coefficient or concentration index, which is really the area between the Lorenz curve and the line of equality, divided by the total area from the line of equality to the corner here. And so 0 would reflect complete equality, 1 would reflect complete inequality, and the further away we are from 0, the more we're talking about a concentration or inequality. But when we take a look at proportion of the population by neighborhoods, what we're really interested in are those mechanisms or those social determinants. For now, I'm just going to show you income quintile, because that's where some of the previous data, as I showed you from mobility, came from. But we can do this and have been doing this for other social determinants as well. So here's an example of social determinant of health after tax household income. And if we split up our population through the DAs with respect to those in highest income and lowest income quintile, this is the epidemic curve, excluding cases in long-term care among long-term care residents. And what you see is a very different epidemic curve in neighborhoods of lowest income quintile versus neighborhoods with highest income quintile. And this could be a proxy for us with respect to how the population could be stratified with respect to heterogeneity. Of note and of interest, you see this kind of crossover that happens early on in the outbreak. And one would imagine that that has to do with travel-related cases, and it's true. So if we take only a look at travel-related cases, we see that the epidemic curve is really in the highest income quintile. But interestingly, prior to that crossover happening, non-travel related cases were also in the highest income quintiles, telling us a little bit about who mixes with whom or who must contact whom with respect to income quintiles and at a neighborhood level before things are cross over into lower income neighborhoods, for example, telling us a little bit about potential assortativity within networks and how the infections have passed through. And so similar to what we did with the Gini coefficient and Lorenz curve by proportion of population, a common way we look at this, and particularly in HIV and STIs, as well as other health indicators, is to think about this by social determinants. So what you see here is we take what happened by the cumulative, by August 21, the cumulative distribution of cases by income quintile, or in this case, actually, we've done decile here. And on the x-axis, you have the proportion of the population that falls into this income decile by ranking. And on the y-axis, once again, we have the proportion of cases. And what we learned from this is that we can have 30% of the population living in the lowest income neighborhoods or dissemination area. And this 30% accounted for 46% of cases. We can measure, or not measure, we can estimate the area between the Lorenz curve and the line of equality. And that's our Gini coefficient. And we can conduct bootstrapping to generate 95% confidence intervals. And what we can do with this is also look at this and see what happens over time. So if we take a look at mutually exclusive time periods, early on in the epidemic or outbreak in the city of Toronto among non-long-term care residents, lower income neighborhoods disproportionately less likely to account for cases. Very quickly, and you saw that crossover in the epidemic curves, more likely to account, lower income neighborhoods, more likely, disproportionately more likely to account for cases. And it's kind of steadied off thereafter at this Gini of around 0.25, 0.26. And what we're working on now is actually stratifying and stratifying a transmission model to calibrate to the Gini coefficient over time. So we haven't gotten there quite yet. So what I'm hoping to do is share some work around illustrative insights where we wanted to try to answer that question around this heterogeneity in risk and heterogeneity in intervention uptake or access or reach. So we thought about asking ourselves, what are the epidemic consequences of heterogeneities or inequities in risks and resilience and intervention access and reach? And here we're going to just have a very a simple illustrative COVID transmission model where the demographic groups are stratified into two populations, those at higher relative risk, those are at lower. And we're only going to do this through contact rates. We set our R0 at the beginning, and therefore we're able to generate a beta that applies to both by using the by essentially estimating I should say reverse calculating beta based on setting the R0. We have two populations, higher and lower risk, but we have to have contacts between them. And what we decided is that we were going to approach this like we approach HIV and STIs with respect to populations that also come into contact with each other through either some degree of proportionate mixing based on the number of contacts that are available, as well as some degree of assortative or like with like mixing. And proportionate mixing is really given by the number of contacts available by each subset of the population. And we can set our epsilon to give us a range between fully assortative to proportionate mixing. And in this case, just showing one illustrative scenario where we set epsilon to 0.5, somewhere in between, and starting with an R0 of 1.5. This is a simple version of the model. It's a deterministic compartmental model. And testing and isolation rates are same across these two groups, which we're going to pretend are sort of represented by these neighborhoods for now. Individuals, when they become infected, can be exposed. A proportion, and for this particular scenario, the parameters that I'm showing the results for, where 40% never become symptomatic, so they're fully asymptomatic throughout their course of illness. And for the purpose of this exercise, we've actually haven't set them to be able to be detected and isolated. The remainder of individuals go on to develop subclinical and then clinical or symptomatic infection, a subset of whom are diagnosed early through, for example, contact tracing quarantine measures or rapid testing from the onset of symptoms. And then they may go on to develop severe or non-severe infection. And then the remainder are not yet diagnosed, but then can go on to be diagnosed develop severe or not be diagnosed with non-severe infection. We assume that every individual who's severe has been diagnosed, and those with severe infection experience some degree of infection or associated mortality. The remainder recover. This is a closed population for the purpose of this exercise. And we assume that individuals who are high risk remain high risk, individuals who are low remain low, and then there isn't turnover between the two groups. But because of the way we set up our contact matrix, we have individuals who are in these compartments called infectious but diagnosed, severe and again, infectious, symptomatic but diagnosed. And these individuals, we say, have zero transmission. So we set their beta, the health state specific beta transmission probabilities to zero, but we also say, well, what if they actually had fewer contacts? So the assumption being, for example, they have 2 contacts per day. That actually reduces the number of contacts in our base case scenario. And we actually end up having to compensate for that with slightly more contacts between higher risk and lower risk to compensate for the disproportionately more cases and isolation among the higher risk. It's a small compensation, but it does take place. We don't allow for any compensation through the deaths that occur with respect to other individuals having to make up contact rates as a result. So what do we find? Well, again, this is an illustrative scenario. We use parameters based on our work from COVID transmission modeling. But what I'm going to show are some of these insights that we wanted to bring into our larger model. So for example, here's the red line showing the base case as the prevalence in the high risk group and prevalence in the low risk group. Prevalence reflecting the fraction of each subset of the population that is infected or not yet recovered. And we apply a 25% reduction in contact rates and assume that across both subgroups or both neighborhoods, people can do this feasibly. So if you remember, our high risk individuals living in the higher risk neighborhoods had contact rates of about 20 per day. Those in lower risk neighborhoods had contact rates of 10 per day. Both of them reduced by 25%. And what we see is this is from the base case, everyone reduces their contact rate, base case, everyone reduces their contact rate. We started off with different levels of prevalence in the 2 neighborhoods, and we see relative reductions in both. But what if we apply 25% contact rates, but individuals living in the higher risk neighborhoods are maxed out with respect to what they can actually do? What if they can only feasibly reduce their contact rates by 10%? For example, if individuals in higher risk neighborhoods provide essential services, they might have a cap on how many contacts they can actually reduce. While everybody else living in the lower risk neighborhoods, for example, reduces their contact rates by 25%. And that's shown in the dashed black line here. And in both subsets of the population, you can see that we essentially think that we can do really well, but when we have this disproportionate reach or access or feasibility or uptake of interventions, particularly among the high risk population, for example, or individuals at higher risk, then we really attenuate the impact of this strategy that we're trying to implement or advocate for. But then what does it do to these measures of inequity? Well, so what we saw, as you saw in the previous graphs, is if we have our base case, this is our higher risk, our lower risk, we apply this intervention so that everyone reduces their contact rates by 25%. Remember, reducing contact rates by 25% among the higher risk doesn't get us as far as reducing contact rates by 25% among lower risk. It's not the same. And therefore, we still see, we get this reduction, we still see this difference. And then we have this inequity in reach. Not everyone is able to actually do what was asked of them in terms of reducing contact rates. And interestingly, even though we get an overall reduction in number of cases, the overall reduction in cumulative infections, when we actually compare these relative rates, or what we call the cumulative incidence rate ratio, at the end of this time period, in particular with the unequal access or intervention reach, we see more inequity. But even when we apply this equal reach intervention, and that reflects that we needed to do more for those at higher risk, that equal intervention output may not be enough. And that's sort of a hallmark of inequity or addressing inequity. So showing you some illustrative results, which are part of what we are building in terms of the building blocks of a larger model, where we would like to apply metapopulation modeling of our SARS-CoV transmission model to 5 public health units across the Greater Toronto Area, but rather than patches or populations across every single neighborhood, really collapse them into the clustering of these social determinants of health that tell us about exposures, such as household density or occupation, and then calibrate them to Gini over time by those risk factors, and then link them to long-term care transmission modeling with respect, or a facility-specific modeling with respect to how neighborhoods across these social determinants may be linked to where folks work and live in terms of these facilities. And as you said, we're working on some efforts to look at mobility. And the way we'd like to look at mobility metrics or intervention uptake is by answering the question, what role could intervention uptake by social determinants have played in the spatial concentration of cases? And for that, what we can adopt is a mediation analysis where we take a look. We've seen relationship between, for example, the social determinants and COVID. Well, to what extent could they be mediated by mobility metrics or changes in mobility? Fortunately, we only have these data at the area level, not individual, but the extent to which this relationship may be attenuated once we account for whether or not people were actually able to shelter in place or not by social determinants. And in essence, what we would like to ask is something that came out of the illustrative work is, if physical distancing or certain measures don't work for everyone, could we have further concentrated the outbreak further? And so those are sort of the data and some of the modeling work that is in progress. I wanted to finish in the next couple of minutes, giving time for hopefully lots of discussion and feedback from yourselves, is why we decided to take a look at inequity as from the perspective of transmission dynamics. Because a lot of this was actually written out in the guidance for us prior to this outbreak, learning from SARS. What are the core principles of public health? They include equity. Given inequities across society, public health is meant to do more for those who need more. And I think that's reflected in even some of the illustrative work to date. It's supposed to incorporate and capture social justice, principles balancing intervention, burden, and benefit, and importantly, participation. So consideration of why interventions are not reached among subsets of the population by engaging and efforts led by communities who are disproportionately affected. And this is a core principle for HIV and STI public health and guides a lot of our HIV STI modeling and is something that has a role here as well. And characteristics of intervention strategies, I won't go through them all, but an important one is this idea of efficiency and effectiveness, which is really based around tailored interventions by heterogeneity or the actual mechanistic factors that lead to onward transmission. So back to what we've learned from the data. Who is most at risk of, I should say, COVID-19, not COVID-019, in Ontario by June 2020? If we think about this dose response relationship with respect to odds ratios, or even if we take a look at the Gini coefficient work and the concentration index, what they really tell us are about prevention gaps. They're telling us about what conditions still persist that lead to disproportionate risks of acquisition onward transmission, which means how do we tailor our strategies to these mechanistic or either causal and or proxies of causal risk factors. So for example, and there are data emerging on this, but this also comes from a lot of prior work in other respiratory and other infectious diseases, efforts such as paid sick leave so that individuals under quarantine and isolation are not pressured to work given concerns about meeting basic needs. Housing support, as we did for shelters, but thinking about a voluntary community-led housing support for those under quarantine isolation, particularly among those who live with many others in the home or via multi-generational households, which are correlated with household density. And overcoming these barriers to testing in healthcare, be they context-specific, physical, or sociocultural barriers, and including in particularly community engagement through that effort. Lastly, or not lastly, but just prior to lastly, some things that I learned from HIV/STI transmission modeling that was sort of hammered into me, no pun intended about the hammer, that applies to COVID and all infectious diseases. And as a community of epidemiologists, as public health, as modelers, as data scientists, all of us, the words we use to describe populations served by the analysis and the work we're doing, they do matter. And I hear this from working with communities who are affected, most affected by COVID. People are not vectors. We need to think about whether we say, what we mean when we're describing the conditions that lead to risks or resilience versus people themselves. And the other feedback that was given to me, even as we were doing some of the early work, because we didn't account for a lot of heterogeneity, is to, Sharmistha, be more explicit in what you modeled to avoid modeled with respect to interventions, to avoid mistranslation in public health practice and implementation. So when I modified contact rates in my model, was I talking about restrictions, or was I talking about any strategy that would lead to reduction in contact rates? And to be mindful of what that means for mixing patterns, among whom these contact rates were changed, and under what conditions. So the feedback I received is to be more explicit about exactly what I turned on and off and increased or decreased. And what did that do even in the base case scenario, for example, when we haven't changed contact rates per se, but just put individuals into isolation. So some final conclusions, early work by necessity, we had to use a lot of relative homogeneity, and we're learning a lot from the data now, beyond age and but starting to look at other mechanistic factors. And that the data are pretty consistent, not just in Canada, but elsewhere around this construct of heterogeneity. And what does that mean? It's important that we recognize heterogeneity, but I think where it could really guide us is in helping us with respect to tailored strategies. The more that we're able to provide, modeling efforts to look at, well, take all versus one size fits all versus this, a tailored approach. Recognizing that what we've learned from many other infectious diseases is that it's always consistently harder to do tailored strategies, tailored efforts, but that it's probably where we want to be going. If we're thinking about our public health response being part of affirming human rights and aligning with the aspirations of equity, which is a core principal component of Canada's healthcare system. And with that, I'd like to thank lots of folks that we work with, the folks who fund us, the modeling consensus table that has galvanized a lot of this work, and would love your feedback on thoughts on how we can keep moving forward with respect to understanding and modeling heterogeneity, particularly as they relate to social determinants. Thank you very much for your time.
Thank you very much, Sharmistha. So a very nice talk and for addressing some of the most fundamental issues of COVID-19. I think it's time now for question comments, and if you can raise your hand and unmute yourself, or you can send your questions through chat. Kumar, our chair of the consensus table, you have a question?
I keep saying that one of the very, very few benefits of being to the institute is I get to ask questions. Anyway, so Mr. Really nice talk. I think this kind of analysis is much more of it needs to be done. Did you do other Gini plots besides the income distribution, other indicators of inequalities in distribution?
Yes, so we're looking at it across all of the same social determinant indicators that were presented with the Ontario analysis, in particular, proportion visible minority, educational attainment, and household density. We've added on multi-generational households through different definitions as well. And we're seeing similar interesting plots through that. And part of why we're doing that, including this time, not just household density, and but also multi-generational households through different definitions of multi-generational households, be they older with young children, school age, or be they older with occupational age adults, is because at least, I haven't shown this, but through similar illustrative modeling, when we just try to understand what might happen, we're seeing differences in what age spillover could look like by neighborhood, depending on concentration of multi-generational households by those definitions. So yes, so hopefully maybe even by next week, we should be able to share some of the other Genie plots and how they've changed over time.
That's really interesting. The change in time is especially fascinating. The other comment is that it seems to be a general principle when you do this inequality analysis that the way inequality changes at the extremes is different. And I think you also observed that, right? When you make a change, the different extremes change differently. And that's a general principle that I think needs to be better known, probably is not as well known as to be. Right, thanks.
That's helpful, Kumar, I think as well, because sometimes it seems like things are getting worse, and teasing apart what are the underlying sort of baseline conditions that led to inequality versus sort of how changes through the natural dynamics change that versus our interventions alone, and that changing over time. And I think that's the beauty of sort of mechanistic transmission modeling to some extent, is you can start teasing that apart a bit.
Jiahao, it would be very interesting to have health economic analysis about multi-generation household where you have home quarantine cases, whether it would be more beneficial to simply provide them a isolation place to that health economic consideration that might be even more efficient.
Yes, I think that would be really helpful, as well as sort of the effect of reducing. So some of the data coming out also suggests that the time from symptom onset to reporting a result, which we can use as a proxy measure for isolation, also vary by these social determinants as well. So looking at these, those efforts of increased resources that would be required to sort of really get testing out to communities. And how, like neighborhoods where there's not just the household density element, but also sort of a sociocultural element around trust of health systems and other elements that for which there's a resource input that would be needed, in addition to, as you mentioned, the isolation support or quarantine support.
Great. Other questions, comments?
Yeah, hi, this is Mark Penny. I had a question about some of the data behind some of the models. You presented this example where you have sort of a high-risk group and a low-risk group, and you had to specify, how many contacts does each of those group members typically have, and what does the mixing look like? When you're doing the sort of more refined model about the health networks or the health organizations in Ontario, do you have a source for, say, like, how do some of these social determinants of health relate to average number of contacts, and how is mixing, and do you have a data source for some of these things?
So we hope that the Connect study may be able to support some of that by relating where folks live with respect to social determinants. Unfortunately, there's been a lot of focus on contact patterns by age group and to some extent by occupation, but less so by sort of in which neighborhoods they may live. But that hopefully will be one source. And then the second is through some of the mobility, the baseline cell phone data with respect to where cell phones seem to travel with respect to within these, not just geographic neighborhoods, but geographic neighborhoods that are actually stratified by those social determinants. So yes, until then we're left with sort of that spectrum of assortativity to proportionate.
Yeah,
and
thanks.
fitting to the data. Sorry, Mark. Yeah.
Oh, no, great. That's, I haven't heard of the Connect study. Maybe I should have, but could you say a few words about what that is?
So it's led by Mark Brisson, and there'll be data on, and I believe it's already been presented, but I can't remember. But it might be something that would be great for this Fields symposium as well, from prior to COVID, during COVID, and we'll have data, the team will have data sort of throughout that process. So I'm not directly part of that study, but it's essentially asking folks to fill in with respect to, how many people they've come into contact with, focused largely around age, but also starting to ask a few other questions as well.
Oh, that's
and this is a key part of, like, for those of you who do HIV STI modeling, it's sort of a key part of our data collection is, who sort of has sex with whom, but it's often more challenging across these other proxies. Sorry, Mark.
Yeah, that's excellent. I appreciate that. I'm looking forward to seeing more about that data when it comes out, because as you said, I'm mostly familiar with the age-based stratifications, and yeah, some more regional or health factor related ones would be very helpful to have.
I will add that, and I didn't show this, but happy to share it through the modeling consensus table or through Jianhong and Kumar and Sarah. What we've been able to find when we take a look at diagnosed cases by occupation. So for example, when we looked at diagnosed cases among long-term care workers, and then looked at where they live, two things come out. They disproportionately live in hardest hit neighborhoods. So you think that they would sort of be proportionately, sort of quote unquote, this is the wrong word, spread, or distributed by neighborhoods with respect to how hard they've been hit. They're disproportionately more so in the hardest hit neighborhoods. And they disproportionately live in neighborhoods with the highest visible minority and lower educational attainment. And so those elements also tell us a little bit about mixing between those risk strata, where we're trying to separate our neighborhoods by that, and sort of their connection to long-term care facilities.
Yeah,
we
excellent.
only have that for cases, not for people who actually, all individuals who work. Necessarily.
Yeah, excellent. Yeah, thank you.
And one way I understand publish a paper, especially in the next, the one you just mentioned, is highly not political, but it's highly sensitive when you to this two-strata model.
Oh, sorry, the long-term care work or the yeah, no, what we're the way we're approaching is just to see if we can draw any inference from the case data with respect to where folks live, in terms of telling us a little bit about assortativity between neighborhoods and facilities. So we're trying to frame it a little bit around a methods piece, but yeah, I think one of the key elements is also sort of working with communities. So we're lucky in that we're partnered with projects and interventions in long-term care homes, through which we're working with the Association of Personal Support Workers. And so these are data that and discussions we have with them, and with respect to how to also present it.
Sorry, I was saying that some of us are experiencing connectivity difficulties, so I lost some of what you said. I don't know if others are having the same trouble. But so, Jianhong, are you back on?
My battery is almost run out, so I'm using data, but I'm back on, yes.
Okay.
Any other questions, comments? So if not, so again, the talk is videotaped, and if you click on her name, and you will see lots of papers and media interviews and
just papers.
And papers. So,
just papers and reports.
Yeah. So thank you very much, Sharmistha, for coming to the fields and for your contributions.
Thank you, everyone, and please feel free to reach out and give any feedback, and especially constructive criticism. Thank you.
Thanks. Bye.
Thank you.
Bye.